Hello, dear students and friends. In my class series today, I would be discussing a topic which is of clinical importance. In our ANC clinics, very often we come across women who are pregnant and suddenly they come with an ultrasound scan showing a birth defect in the baby. Well, this situation is a dilemma, management dilemma, as well as counseling dilemma, not only for the women, but for the clinician as well. So, the topic which I would cover is birth defects, a gynecologist's approach to identification and prevention. Now, an overview of birth defects. These are abnormalities present from birth. Congenital abnormalities, however, can be classified as lethal, severe, or mild. Neural tube defects are the most common birth defects affecting the brain and spinal cord. These defects could be structural, functional, and metabolic disorders, and they definitely pose a public health challenge. Globally, 6% of births per year are associated with serious defects. 94% of these birth defects occur in middle and low income countries. According to WHO and March of Dimes joint report, 7% of neonatal mortality is the result of birth defects. So they are a significant public health problem. If you look at the scenario in India, India is the most populated country and the annual prevalence of birth defects is 6 to 7%. India reports 1.7 million birth defects annually, and the commonest ones, as per Minds of Dimes report, are congenital heart disease, congenital deafness, and neural tube defects. Now, the causes and consequences are tremendous. These birth defects have a social and economic impact, poor quality of life, lifelong disabilities, and adverse impact on quality of life. It affects emotional functioning, mental health, self esteem. It has a tremendous economic burden because of the costly treatment and non medical and out of pocket costs to individuals as well as caregivers. Of the ethical issues, antenatal issues, religious issues could be related with abortions and MTP. Postnatally, also, it has a tremendous impact. Now, our concern is regarding prevention of these birth defects because of the potential of preventing morbidity and mortality. This can be done in these four ways: pre pregnancy counseling, reviewing the family and genetic history of the couple in respect to genetic disorders and birth defects, genetic counseling to educate them on the potential options for pre pregnancy and early pregnancy screening of the offspring, management of chronic conditions like diabetes, counseling about adverse effects of smoking, alcohol, and drugs, and assessment of immunization status of women. Some medications, prescription as well as non prescription ones, should be reviewed with respect to safety. There is a tremendous role of folic acid in prevention of neural tube defects, which should be given prior to and during pregnancy. The most important, however, is early identification of these defects as soon as possible after conception and patient counseling regarding surgery, continuation, or termination of pregnancy. Folic acid supplements do prevent neural tube defects, but other maternal risk factors to be addressed to prevent birth defects include nutritional factors like iodine in addition to folic acid, prevention of infectious diseases, maternal infections, treatment of conditions like diabetes, obesity, some lifestyle factors like alcoholism, environmental factors like radiation and environmental pollutants. Folic acid supplementation can reduce these defects. 400 micrograms every day is recommended to all women of reproductive ages. In high risk patients, however, a higher dose of folic acid, 400 micrograms, or even 5 milligram tablets, which are available, can be given every day. Awareness about planned pregnancy should be increased, and food fortification with folic acid is the best way to fulfill folic acid requirement in women of reproductive ages. Now, antenatal diagnosis of these birth defects include the various screening tests to identify. Then, if there is an abnormal result, certain diagnostic tests to confirm the presence of defect and then take a decision. Diagnostic tests could be an ultrasound, chorionic villus biopsy, or an amniocentesis. The detection rate of an ultrasound 40%, 11 to 14 weeks, second trimester 35%, third trimester 15%, and overall detection rate is 90%. Now, in addition to those ultrasound markers, there are certain biochemical markers which are useful in screening. The first trimester marker, first trimester combined with ultrasound, second trimester markers, and the integrated screening, and non-invasive prenatal tests. If you look at the first trimester markers, age is an important factor. In addition to that, alpha fetoprotein, beta HCG, PAP-A, a new pentamarker which includes alpha fetoprotein, beta HCG, PAP-A, dimeric inhibin A, and placental growth factor. Then combined first trimester nuchal translucency and these biomarkers. The second trimester, a triple marker and a quad test. Triple marker includes alpha fetoprotein, beta HCG, and estriol. Detection rate is 65%. Quad test, in addition to above three, inhibin A is included, and the detection rate increases to 81%. Now, integrated screening is always advised. The first trimester and second trimester markers combined with a neural translucency, that is the ultrasound marker, the detection rate increases to maximum 96%. A test which is non-invasive and which identifies birth defects is the cell-free fetal DNA. Its detection rate, however, is very high, more than 99.9%, and a false positive rate less than 0.1%. This shows the various timelines in which these tests are done and the detection rates, as we've already discussed. Now, the advantages of cell-free fetal DNA, which is a secondary screening test, compared to CVS and amniocentesis. Cell-free fetal DNA is non-invasive test. Screen positive require, however, a confirmatory diagnostic test. It detects trisomy 21, 18, 13, and some sex chromosome aneuploidies and some microdeletions. It does not screen for open neural tube defects. It is not well validated in twin pregnancy, and screen negative patients do not undergo further diagnostic tests. Thus, unexpected chromosomal abnormalities that can be identified by an invasive test will be missed. It may delay definitive diagnosis and management since a positive screen requires further testing. But still, it is a very good screening test. However, the diagnostic test is invasive, but it is definitive. Conventional G banding will detect all numerical and all large structural chromosomal abnormalities. Microdeletions, microduplications are detected by microarray. Amniotic fluid is tested for alpha fetoprotein to screen for open neural tube defects. These tests are validated in twin pregnancy. Unexpected chromosomal abnormalities that can be identified by an invasive test will be detected. The direct route to a definitive diagnosis. So, by a diagnostic test, we get the definitive diagnosis, but a secondary screening test in the form of cell-free fetal DNA gives us a lot of information, and that too earlier. Now, in the early scan, we have the NT scan, which is performed at 11 to 14 weeks of gestational age. It can diagnose a wide range of fetal structural abnormalities. It has the potential to detect about half of the prenatally detectable structural abnormalities, and early detection of birth defects impacts the parental decision and thus associated with lesser trauma. That is in the first trimester. Now, certain malformations and their detection rates, 100% detection of acrania, anencephaly, ectopia cordis, and cephalocele. 50 to 99% detection of cystic hygroma, double outlet right ventricular flow defect, Fallot's tetralogy, gastroschisis, etc. Up to 49% detection of spina bifida, hydrocephalus, skeletal dysplasia, facial cleft, Dandy Walker syndrome. And the conditions which it cannot detect are corpus callosum agenesia, bladder extrophy, cystic adenoid malformation, cerebral hypoplasia, duodenal atresia, hydronephrosis, renal agenesis, duplex, kidneys, bowel obstruction, and extralobular sequestration. It may be noted that these anomalies may develop later on, and therefore a repeated scan in the second trimester and late second trimester is essential for identification of some of these anomalies. Now, the markers for birth defects which can be seen in an early scan: an increased nuclear translucency, which is more than 3 mm, helps in identification of fetal aneuploidy, certain genetic malformation syndromes, and certain cardiac malformations. If there is an abnormal ductus venous waveform and tricuspid regurgitation, which is now a part of the first trimester detailed scan, it can help in identification of congenital heart disease. Absence of calvaria and brain abnormalities suggest anencephaly. Echogenic amniotic fluid suggests fetal acrania, occipital hernial mass, and encephalocele. There are some other defects which can be helpful in identifying holoprosencephaly and open spina bifida. And this can be done in the first trimester. Now, some cardiac anomalies which can be identified in this scan: a complete AV septal defect at 13 weeks in a fetus with Down syndrome, or this picture depicts a increased nuclear translucency in a 12-week fetus. Then normal nasal bone ossification at 12 weeks, absent nasal bone ossification at 12 weeks in a fetus with trisomy 21. CNS abnormalities: echogenic amniotic fluid in early stages of fetus in anencephaly, or anencephaly 2D and 3D assessment. Absence of calvaria is indicated with open arrows, and the brain structures are floating in amniotic fluid as it has been seen. And here you can see the typical Mickey Mouse or exencephaly appearance on a 2D scan. So this is anencephaly. Now, some other CNS abnormalities which can be diagnosed in an early scan: an isolated encephalocele in the first trimester, or an A-lobar holoprosencephaly in the first trimester, large communication between the cerebral ventricles and fused thalami, and the typical absence of butterfly aspect of choroid plexus. Now coming to the second trimester anomaly scan, this is performed between 18 to 22 weeks of gestation. It is a standard of care for fetal anatomical assessment. Some of the malformations like renal agenesis, bowel obstruction are not diagnosed in the first trimester and therefore are difficult to diagnose before 20 weeks. And they are diagnosed in this scan. So the various anomalies which can be detected: hydrocephalus, agenesis of corpus callosum, congenital cystic adenomatoid malformation, cardiac structural malformation, cystic kidney disease, horseshoe kidney, Dandy Walker malformation, duodenal atresia, fetal goiter, intra-abdominal tumors, gonadal cyst, Hirschsprung disease, and isolated fetal ascites. The markers of these birth defects, which can be seen on a scan: a head circumference less than 3 standard deviation helps in identification of microcephaly; a cavum septum pellucidum, corpus callosum, which connects the left and right lobes of the brain. If it is not visible, it identifies brain anomalies. The fetal face, the tips of various structures like nose, upper lip, lower lip, and chin, if they are not visualized in the same coronal image, it denotes micrognathia. Diaphragm may be seen in sagittal plane. Intact diaphragm is seen on each side, especially posteriorly near the spine. So there could be congenital diaphragmatic defects if it is not seen. The fetal heart, incorrect positioning with intraventricular septum, if it is not at an angle of 45 degrees, denotes heart-related abnormalities. Then a fetal chest, If there normally should be cystic or echogenic areas in lungs. If they are seen, then cystic adenomatoid malformation or some lung abnormalities can be identified. Fetal spine spreading of laminae to form more obtuse angle triangle denotes open spina bifida. Femur length less than 2.5 centile denotes aneuploidy and skeletal dysplasia. Humerus length also less than 2.5 centile denotes aneuploidy. Nasal bone length, if there's a hypoplastic nasal bone, that is diagnostic of Down syndrome. Then some anomalies as can be seen in these pictures: microcephaly, spina bifida, axial plane, sagittal plane, coronal plane, encephalocele, cranial meningocele, left diaphragmatic hernia showing the stomach, and right diaphragmatic hernia, evisceration of the liver. Then thorax in thanatotrophic dysplasia, a narrow chest, large VSD, perimembranous, and muscular ventricular septal defects. Then facial cleft, which is unilateral cleft lip, bilateral cleft lip, anencephaly, acrania. Now, a third trimester ultrasound usually performed during 28 to 32 weeks. The potential to detect some of the structural defects which develop later in pregnancy and hence are not apparent on an earlier scan. It detects anomalies which might have been missed out in earlier scans due to resolution problem, fetal position or fetal size. It detects anomalies developed due to particular maternal events such as infections which may occur later on. Anomalies of the urogenital system, hydronephrosis, unilateral renal agenesis, etc. Of the heart, small ventricular septal defect, mild pulmonary stenosis. GI abnormalities would be seen in the third trimester like pyloric stenosis, intra-abdominal cysts, CNS abnormalities like a developing hydrocephalus, a small spina bifida without hydrocephalus, and agenesis of corpus callosum. Achondroplasia, hydrothorax denotes trisomy 21. Others, like an ovarian cyst, can be identified, hemangioma, and fetal hydrops would be identified. So, this shows kidney showing a large hypoechoic area in the center of the kidney, renal cyst. Infantogram, which shows calcification of aorta and iliac vessels. Now, spina bifida. Many defects can be prevented, but once spina bifida develops, it cannot be prevented. The only thing which can be done is a posterior closure. But lifelong disability occurs, and there is a spina bifida foundation which helps in managing these babies with spina bifida. It provides a parent support group as well. Guidelines for the care of people with spina bifida is an initiative of the Spina Bifida Association. Care coordination is essential part of multidisciplinary spina bifida care team and vital to improving health care and wellness outcomes for people living with spina bifida. These guidelines help to ensure that all people living with spina bifida receive the best and most up-to-date care possible. And the goals of care coordination are to gain access to and to integrate services and resources, to link service systems with the family, to avoid duplication and unnecessary cost, and to advocate for improved individual outcomes. NTDs can be open or closed, and the type finding of determines the most important aspect, that is counseling. It is important to convey information about medical care and lifelong impact of spina bifida in a value neutral, collaborative manner while seeking from families an understanding of their needs, values, and beliefs. We must provide education regarding all treatment options available to women carrying these fetuses, including fetal surgery, postnatal closure, adoption, and termination. Must maximize health and participation in emerging adult milestones throughout the transition process for individuals with spina bifida. It provides updates for families regarding a probable trajectory for adult function and expectations. maximize self-management, independence, quality of life, and transition to adulthood outcomes by addressing mental health changes. Expand the discussion of sexuality, contraception to these babies who have grown up with spina bifida. Marriage, childbearing issues, genetic counseling, and folic acid supplementation. Now, here is the list of some anomalies which are identified later on, and counseling and decision play an important role in management. Hydrocephalus, then microcephaly, agenesis of corpus callosum, some skeletal dysplasias, esophageal atresia, duodenal atresia, and genitourinary atresia, and various tumors which are developing at different sites. This may have implication on both the mother and the fetus. In these situations, ex utero surgery is an option, but there is a role of fetal surgery as well. Open fetal surgery and fetoscopic surgery. Postnatal repair or amelioration of the lesion is the gold standard treatment for birth defects. Rapid advances in imaging and instrumentation technology has led to development of novel intrauterine interventions for most common fetal anomalies. Devastating anomalies such as meningomyelocele, congenital cystic malformation of lung, twin-to-twin transfusion, and sacrococcygeal teratomas have successfully been treated with fetal surgery. Surgical intervention on the fetus and then again placing the fetus inside the womb or the uterus, the aim being to continue intrauterine gestation as long as possible. This is open fetal surgery. But in fetoscopic surgery, laparoscopic and video assisted surgery can avoid large hysterectomy to reduce the incidence of preterm labor postoperatively. However, we've seen the ultrasound markers and we've seen various defects which can be identified on ultrasound. A word of caution here is all fetal genetic syndromes cannot be identified prenatally. Ultrasound can pick up structural abnormalities, however, it cannot be used alone for definitive diagnosis of many chromosomal syndromes. Dedicated, meticulous, and systematic approach needs to be followed for every patient. To summarize, birth defects are a major public health concern owing to high associated morbidity and mortality. Some birth defects can be cured, however, they can also be prevented by nutritional changes like avoiding infections, also by managing particular medical conditions, avoiding alcohol, smoking. Folic acid supplementation prior to pregnancy and during early pregnancy has the potential to prevent up to 70% cases of spina bifida and neural tube defects. Early diagnosis of birth defects is advisable for continuation or termination of pregnancy with minimal trauma to the patient. So it should be done in the first trimester. An anomaly scan is the principal diagnostic tool for birth defects and should be performed 3 times. Once early scan 11 to 14 weeks, then the second trimester scan as early as 17 to 19 weeks, and the second scan 24 to 26 weeks to identify those anomalies which develop later. Spina bifida cannot be cured. Certain procedures like back closure can make the patient's life easier and comfortable. Some anomalies like hydrocephalus, microcephaly are progressive and they have a late onset. It should be kept in mind that not all the anomalies are detected prior, and thus each patient needs dedicated, meticulous, and systematic approach. Thank you for a patient hearing, and do subscribe to my channel to keep yourself updated.